So it's my pleasure to introduce our host, Dr. Beth Ruben. She currently is the director of dermatopathology and a consultant dermatopathologist at the Palo Alto Medical Foundation. She also works as a volunteer professor of dermatology and pathology at UCSF, where she spent 11 years, certainly in one of the country's busiest academic dermpath practices. And while at UCSF, she served as the director of the Dermatopathology Fellowship, previously serving as UC Davis's dermatology residency program director. She's held numerous leadership roles in the AAD, the International and American Societies of Dermatopathology, and among other things, she's recognized as one of the country's leading experts on nail diseases. And so it's my great honor to introduce my colleague and good friend, Dr. Beth Ruben. We're certainly honored and pleased to have you, Beth.
Well, thank you, Tom, for the lovely introduction and for inviting me to host this Sagas Happy Hour. This is going to be hopefully a lot of fun. And Tom and I go way back, and I just want to thank him again for all of his support of my career. He has shared really interesting cases with me and just kind of been a wonderful support to me over the years, and I very much appreciate it. So some of the learning that I'm sharing with you today is due to Dr. Davis as well. So let me share my screen, and let's see here. So what we're going to do today, let's see, can you see everything here? Yeah, you can. Okay. Let's do this. All right. So what I'd like to do, so I know that your usual format is to go through unknown cases, but I find when I'm talking about this subject, that the whole subject is one great unknown, the great unknown for most people, not just for residents and fellows in training, but even for practitioners of dermatology and dermatopathology and pathology. So what I kind of like to do today instead, and I had the permission of Dr. Davis to do this, is to basically take you on a little tour of the nail unit from the ground up, basically from the basics on forward. And so think of yourself as on a little hop on, hop off bus, and hopefully you'll be doing more of this type of touring, which should be a lot more fun in the near future as the world opens up to us again. But for now, you're stuck on this tour for the next hour. And again, you can hop off anytime you like. But the objectives for the next hour is I'd like to review basic nail unit anatomy and histology with you. And I know when I was in training, I didn't really get that type of teaching on this particular subject. So hopefully this is going to be something new for you. And then let's take a look at some of the different specimen types that come in. I'm going to talk a little bit about dermatologic surgery, and I think we might even have some podiatrists on our Zoom session today, and this of course will apply to you as well. And after that, a little bit of talk about submitting those types of specimens and ways to maximize the processing to get the best result out of those very difficult to obtain specimens. And again, I don't have, I won't have loads of time to do that, but I want to at least spend a little bit of time on that subject. And then we'll dive into some infectious diseases that are common, inflammatory diseases, and a couple of neoplastic categories as well. So basic nail anatomy. The nail unit and the hair are very similar, and we've probably heard this before. They both produce something. So the hair produces a hair shaft, the nail produces a nail plate. And so you've got this germinative component, the matrix, which provides most of the nail plate, and then the nail bed, which is responsible for possibly a tiny contribution to the undersurface of it. And then you've got, again, the product, the nail plate, you've got framing, you have nail folds and grooves, which kind of hold things in place. You've got the true sheaths that really keep the environment out. So cuticles, the eponychium, which is the undersurface of the nail fold, it produces a special type of cornification and can really seals things off. And then the hyponychium, the last point of attachment out there as you get beyond the free edge of the nail. And then the supportive tissues. There's all kinds of neurovascular tissues, some of them specialized for this location. And then the onychodermis, which has some special properties that we won't have a whole lot of time to talk about today. When you look, for example, at one of your own digits, you can see some of these structures grossly. Proximal nail fold, I think we all know what that is. And then this is the right next to it, the false cuticle, which lies on the nail plate, something that manicurists seem to always want to get rid of, but it is It's not the tightest sheath, which is the true cuticle, which you don't really see too much of, but it's basically the product of the proximal nail fold, and it is an important part of keeping the environment out of this structure. Whenever you see the lunula, you're looking at the distal matrix, and so the distal matrix. Can you guys see my pointer? Okay, I hope so. I think you should be able to. But the matrix basically goes like this. You see the distal matrix in the lunula, but it goes back beyond the proximal nail fold, and depending on what digit you're on, you'll see more of the lunula. So it tends to be more obvious on the great toes and the thumbs, for example, and kind of less conspicuous on the other nails. And then you've got from the edge of the lunula out to the onychodermal band, which is the last point of attachment of the nail plate to the nail bed. You've got the nail bed. So this is your nail bed. Under here, it reverts to kind of more like acral skin, and you've got your hyponychium here, and then you've got your lateral nail folds too. All right, so I love this little diagram from an older edition of Bologna, but it's just sort of gives you a sense of the relationship of the nail unit to underlying structure. So of course, it's pretty close to the distal phalanx. So anything that affects the distal phalanx can affect the nail, and vice versa. If a neoplasm in the nail unit can cause osteolysis pretty easily. A couple of other things, there's no fat directly under the nail unit. You've got a dermis, but you don't have a papillary dermis or reticular dermis. It's just the onychodermis. You've got your neurovascular structures. And then another thing to pay attention to is here, proximal matrix, just how close it is to the bone, and also the extensor tendon of the digit. So anytime you're doing surgery, like for example, a complete nail unit excision, you're going to be wanting to be very careful not to get into this structure and end up with kind of a floppy digit. So just a few things to keep in mind as we go on. What about the nail plate? Well, different parts of the nail matrix, as we talked about, and a little bit from the nail bed, contribute to the formation of the nail plate. And the reason we care about that is that if you have something affecting one of those compartments, you're going to have varying nail dystrophy. So for example, the top of the nail plate is formed from the proximal and dorsal matrix, right? So anything that affects those areas is going to have a bigger chance of causing a dystrophy, for example, than something that happened in the distal matrix. And when we talk about psoriasis, well, that'll really illustrate this point, but this gives you the kind of the lower portions of the nail plate, and then again, a little contribution from the nail bed. All right, so let's look at it in real images here. Now ignore this, this is not normal. This is the closest to normal I have in my collection of nail unit, because who wants to give a piece of that just for teaching? Not really. So this was a pincer nail deformity, and there was an inclusion of the nail bed, a subungual epidermoid inclusion here. And these are there for various reasons, trauma, etc., but trauma probably number one. But the rest of this is pretty good example. So we've got the proximal nail fold. This would be the false cuticle, the eponychium here, and I'll have some little arrows going in this to show you this again in a moment. The proximal matrix, the distal matrix, and then the nail plate here. And then you've got, of course, your nail dermis. And this has a little fat because it's very lateral, but normally you wouldn't see fat directly underneath the nail unit. So again, a little bit closer look at some of these structures. This pink area here is the keratogenous zone. This is where the nail matrix cornifies abruptly to form the nail plate, and you get this pink keratogenous zone, which I often use to orient me in terms of where I am on the nail unit when I get a specimen. All right, and a couple things to notice here. This is the eponychial epithelium. It has a specific type of cornification that leads to the true cuticle and a little bit to the quote false cuticle, and has a variable granular zone here. And just another illustration here. So the eponychium, or undersurface of the proximal nail fold, dorsal matrix, proximal matrix, distal matrix, starting about in here, and then the keratogenous zone. In the distal matrix, you get these mamelons that are the little blobs of matrical epithelium that look kind of immature, and they angle toward the distal digit. And again, when you get that abrupt keratinization, you form the nail plate here. So let's take a closer look. Proximal matrix, and as you get progressively more distal, the nail plate gets thicker and thicker, right? So here it's pretty thin. Here you can see the eponychium and the granular zone that it often has, the plate, this keratogenous zone, and there's often this cleft that forms here, and at least in histologic sections, but I'm told even surgically. And when a nail avulsion specimen is taken, that natural cleft allows for a lot of epithelium to end up on the underside of the nail plate. So something to keep in mind as we go along today. And here again is this deeper matrical epithelium with this little mamelon. All right, so again, at keratogenous zone, flattening of onychocytes, eventually largely a nucleate plate in normal circumstances. All right, and as we get out past the matrix, we can see the remaining little mamelon sort of petering out here, and we get onto the nail bed. And we'll see the ridges in the nail bed in a minute. In longitudinal sections, sometimes they aren't very obvious, but the ridges are longitudinal too, and we'll take a closer look in just a sec. So we get a flattening here, and we can see the other elements that we were looking at. And we don't have a granular zone in the matrix or the bed. So when that develops, it's abnormal, but it's not a specific abnormality. You can see in lots of different settings. Sometimes you do see the little shadows of the onychocytes here, these little ghosts. Sometimes you do see retained nuclei in the plate, and that's correlates with leukonychia. We'll talk about that a little later. This is a cross section of the digit, and you can see the bone, and so how close things are to the bone here. And this was an amputation specimen for melanoma, so there's a little bit of that here. And this gives you an appreciation of those often very deep longitudinal ridges and the epithelium interdigitates with the undersurface of the nail plate. And this also gives you a look at the lateral nail groove. So when you have things like chronic paronychia, you lose this nice deep attachment here in the lateral nail groove, and the nail plate may end up here, and then water and organisms and things can get in there and cause problems. So again, these are longitudinal ridges. It's really hard for me, even after years and years of dealing with nails, to not refer to these as reedy, but they're not a web-like pattern of ridges. They're just longitudinal, and there's little blood vessels that are in these, not dermal papillae, but in these superficial aspects of the nail dermis. And that gives you an explanation of splinter hemorrhages. So if you whack one of these little vessels, blood gets under here in these little undulations of the nail plate, and that's how you get these longitudinal splinter hemorrhages. All right, so a little bit closer look at some of that. All right, as we get out to the very distal portion of the nail unit, we have what would be the onychodermal band. It's the last point of attachment of the nail plate to the nail bed. And then beyond that, you get into the hyponychium, where you get your granular zone back, and it just looks like normal acral skin. This is probably an osteophyte, so not a normal finding. You normally wouldn't see the bone quite that high up, but again, this wasn't a completely normal nail unit. The onychodermis is kind of something we're learning a lot more about, but may have some specialized functions. It often looks a little bit myxoid, and it can get confusing. You might think when you get a biopsy that, hey, that's a myxoma or something else, but there is a little bit of a myxoid disc here, and you can see some of the specialized vascular structure. So here's a little glomus body here, and of course, these can sometimes give rise to glomus tumors. Very common, painful tumor of the nail unit. So if you're going to do a biopsy here, and permit me to digress for a second, because it's really important to understand, if you're the one doing the biopsy, which one is the best for the disease at hand. And on the pathology side, you really need to understand what you received, so to be able to make some assessments there. So nail clippings, something for the faint of heart, easy to do. Avulsions, not as much for the faint of heart, requires anesthesia, of course. These are good obviously for diagnosis of onychomycosis, but also some nail inflammatory diseases, psoriasis being a big one. Sometimes neoplastic diseases, onychomatricoma, that diagnosis can be made in a nail clipping, for example. Really good as a screening procedure if you're looking at some discoloration of the nail. Is it blood? Is it melanin? You may even see melanocytes. If there's a neoplasm more proximally, you may see melanocytes that started off in the matrix and end up in the plate. So when I'm looking at these specimens, I'm paying close attention to those things. Of course, if you're really worried about a nail neoplasm, again, nail plate sampling is just a screening procedure. And if you think there is something to worry about, you have to go to the source for that. Shaved tangential biopsy is really a great technique. It's great for almost everything you want to sample in terms of the neoplastic end of things, but especially large and thin pigmented matrical lesions. It's really nice because it allows you to visualize the lesion. It is technique dependent. You have to know how to do this technique. It's a little more operator dependent. Usually the nail plate is left behind. I like to see the nail plate if it's submitted, if it's taken off, it should be submitted because it can hold some clues, which we're going to look at as we go along. Punch biopsies are fine. They're great for small pigmented matrical lesions, but as I'll show you, it's a blind biopsy. You aren't really directly visualizing the lesion giving rise to the pigmented band. For nail bed inflammatory neoplastic disease, it's a great technique. Nail bed biopsies tend not to leave much in the way of a nail dystrophy. Longitudinal en bloc excisions is sort of the thing I live for. It's the dream. It keeps everything together. It's the least prone to problems with fragmentation or crushing, retains all the normal architecture, and great for all inflammatory and neoplastic diseases pretty much. So just briefly, again, this isn't a nail surgery lecture, but let's take a quick peek at some of these techniques. So a punch you can do of the bed. If you are distal, you may want to do a telescopic punch where you do a bigger punch to get through that thick, hard nail plate, and then a smaller punch so you can actually grab it and not squash it and pull it out, get rid of it, get it out with scissors, etc. Excisions can be done anywhere. Punches can be done of the matrix, and longitudinal excisions can encompass all compartments of the nail unit. And then the tangential shave. Here you incise and reflect the proximal nail fold. You make a little incision here in the nail plate. When this, again, remember, is pretty thin and pliable, so you can then pull it back like a little sardine can. See the spot that's giving rise to this band, and then just shave around it. So that's a really elegant way to go for pigmented lesions. This is a lovely example from my friend Nilton Di Chiacchio, a nail expert extraordinaire in Brazil, who was kind enough to share this. And here you can see this technique, the reflection of the proximal nail fold, scoring around the actual pigmented macule here, and then taking it out. And then usually this gets put back and everything's sewn back together. This is a punch from my friend Phoebe Rich, another nail goddess. And again, it's a blind biopsy. You're often going right through the proximal nail fold into the distal matrix, as you can see by the lunula here, but you're not really exactly seeing the origin of this band necessarily. This is another wonderful intraoperative photograph from Phoebe. And here you can see a longitudinal excision of a lateral nail band, and the nice result that you get a sort of a narrower nail, but a very good looking and functional nail there. All right. If you're taking out specimens, you can consider to preserve what we like to see as the longitudinal orientation of these specimens, and also to keep them from wrinkling and curling up. You can think about putting them on a nail template if you're someone who's doing a lot of nail surgery. So this was an incisional biopsy for inflammatory disease. It turned out to be Lichen planus. So like I said, rather than bread loafing, it's nice to see this in the longitudinal plane. All right, so if you don't have to be fancy, this is that shaved specimen from before, and you can just use a paper towel or a piece of cardboard or another piece of paper in the clinic and put this on there. If you want to orient proximal to distal, you can put a little mark there to indicate that, and then just float it in formalin, and it usually sticks very well. All right, so what about submitting and processing? So really, if whoever you're working with in your lab should have some familiarity with how to process these specimens. They're kind of tricky. They run from delicate to hard to section because of that nail plate. So I like to supervise the grossing of anything that's complicated. Obviously, a nail clipping for onychomycosis is not a big problem, but anything that required a bigger surgical intervention for a patient, I like to make sure we really handle those with care. And I know Dr. Davis is the same. If you're submitting nail plate and soft tissue specimens, it's better to submit them in separate containers because, again, of that pesky nail plate, which often needs some softening. It is prone to fracturing. It can pop out of the block. All kinds of things can happen. So you don't want to necessarily also submit the soft tissue specimen to as much softening. They tend to do very well, but if you don't have to, that's even better. Again, we like to section these things longitudinally. Softeners are great to use, and I can give you a whole lecture on that, and I'll just show you an example of what a difference that can make. But when I talk about softeners, I'm talking about things like potassium hydroxide, not decalcification solution, which is used to decalcify bone. That is very toxic stuff. It's also very caustic, and usually there's nitric acid in there, and that is a DNA denaturer. So you don't want to use that if you're thinking about molecular analysis that you might need, or certain stains. They definitely are quenched. The proliferation markers are quenched by that type of prep, so don't want to use that. And there's no need to soften the nail. Can use something else. So here's an example, before and after, a case I received in consultation that kind of looked like me, a little bit like spam. I wasn't really sure what was in there at first. The nail plate's broken up. It looked like there was some soft tissue in there, and we didn't re-embed or do anything fancy. All we did was use some KOH solution on this, 17% KOH. You can get it commercially, and lo and behold, there was a lot going on. That we had a nail plate specimen, nail avulsion, plus we had a punch, right? And so again, this is another illustration why to submit them separately. Maybe there would be difficulty sectioning this, and you'd kind of cut through the important sections of your underlying epithelium. So anyway, what a difference. All right, diving in now, nail plate sampling. Again, the easiest thing to do in the nail unit, and we're all acquainted with this for diagnosing onychomycosis and molds and candidiasis, but you can also use it for Pseudomonas infection and diagnosis of psoriasis. It's good for diagnosing whether you have subungual hemorrhage or melanin. Onychomycosis, I think most of us are familiar with the different patterns that we can see, the subungual illustrated here, and then white superficial here, but all different. It can affect any part of the nail unit, basically. This is kind of a typical nail clipping, and you want to take these not from the most distal aspect of the nail where there can be a lot of exogenous stuff going on, and bacterial colonization, which is always a little bit part of the picture. And you want to make sure that you're submitting a lot of subungual material here, because really the infection often starts in the skin and makes its way up in the nail, except of course for the superficial variant. And if you don't have enough of this, the sensitivity of the technique is only about identifying fungi with a PAS stain in this type of specimen is only about 70%. It's better than culture. But if you don't have any fungal material, the sensitivity goes way down. So you want to make sure that's there. And here you can see PAS with loads of fungi in here, dermatophytic hyphae, as you can see here with a little bit of septation and kind of oriented with the nail plate onychocytes. And here in the superficial aspects, also some involvement there. Onychomycosis, we're seeing maybe more of this due to possibly rising temperatures and more tropical climates. And so this is very common in tropical climates. And here you can see it is a very good mimic even of a melanocytic lesion. It's the pigmented hyphae have caused pigmentation here. There's also other types of discolorations there. And usually this is due to pigmented molds and fungi, especially the three that I've listed there. And here's an example of this, where this was actually a punch through the nail plate, which over the nail bed, which is not a good place to sample Melanonychia, because we already talked about, usually it starts the matrix, but it was kind of one of those get lucky samples, because you can see that the issue here is on the surface, where you've got loads of pigmented hyphae here and some big tortuous ones, probably not trichophyton species, but you really can't take it any farther than that. And this is something we also call fungal melanonychia, because the cell walls actually do contain melanin. Getting suspicious about non-dermatophytes is important, because on the microscopic end of things, if it's a non-dermatophyte, it's really important to mention that possibility, because it may alter the choice of treatment. You might go from terbinafine to one of the azoles. And here is an example of something that might have been aspergillus. I never got a culture result, but it has some little sort of 45 angle branching, but it's not respecting these onychocytes really. There's perpendicular hyphae that don't respect those borders. And here's one that's most certainly not dermatophyte. I just saw this last year. It ended up probably being an Aspergillus niger species from a wood cutting injury that got into the nail. So definitely not your garden variety stuff. Lots of fruiting bodies and other crazy hyphae all around. Pseudomonas usually causes green discoloration of the nail, very common in people who are involved in a lot of wet work. And also when patients have artificial nails and there's kind of chronic moisture there, it's very typical. So in vivo, it's a green discoloration, and it's caused from the fluorescein pigment diffused by Pseudomonas. But you don't usually see the Pseudomonas in a nail clipping, and it's pretty hard to find gram negatives on a gram stain anyway, but it's really that diffusible pigment we're looking for. And when it gets into the nail plate, it's actually yellow. So it's this lemon yellow hue. You can see it in routine sections, and without any special stains, you can see it even in PAS stained sections. And so this was something that Bernie Ackerman talked about in his famous Clues book, the lemon yellow hue of corneocytes. And it can often happen not in the plate only, but in the nail bed epithelium as a clue to infection by Pseudomonas. Candidiasis used to be thought of as sort of a colonizer of an already abnormal nail, but we now know that it can be a primary pathogen. And this is a very common presentation as chronic paronychia, but another one, and here you can see we've lost the normal architecture here of all the nail folds, but also presents commonly as onycholysis. And so here is what you're looking for. And this was the same specimen I showed you that had Pseudomonas. You can see the lemon yellow, but also had a lot of yeast on the bottom of it. And we're not talking about just a couple of yeast, because those could even be pityrosporan yeast, just colonizers, but you really want to see a lot of yeast, and there should be small budding yeast, as you can see here in this PAS stain. All right, dermatophytoma is a severe type of fungal infection where the fungi basically walled off a nice little environment for them to live in, and it frequently presents in an atypical clinical fashion, either as a sort of a mass lesion or a pigmented streak. And it's very hard to get rid of. So it's something that may require destructive methods because medications can't get into that zone. And so it's something that you want to mention in a pathology report if you see this kind of loculated fungi. And there may also be bacteria in there as well. And it may be a mixed infection with molds and yeast and all kinds of things. So this was one that I saw early on in my career in nails from my dear friend, Monica Lowry, who really was the one who got me onto that path of learning about nails. And this was a patient who developed what looked like a mass under the nail, but on biopsy, she did even biopsy of some of the soft tissue. Really, the main finding was this loculation of fungi with some funny looking spores and things, so possibly non-dermatophytic, that was giving rise to this lesion. And this is another one, so the pigmented streaking here is due to to a dermatophytoma. And you might even suspect Pseudomonas here as well. And if you did, you were right. We're going to see that. So here you can see this loculation that corresponds to the streak in routine sections. Here you can see the Pseudomonas, that lemon yellow. And then in the PAS staining, you can see these loculated fungi. And as you get closer, you can see that there are some really strange looking fungal forms. There's a lot of kind of balloon forms and really big hyphae and things like that. So again, a clue to maybe a non-dermatophyte species and certainly more severe fungal infection. All right, inflammatory and non-neoplastic disease of the nail unit. You can make diagnoses of these on biopsy. I don't have time to go through all of these today, but a lot of diseases in the skin can manifest in the nail. It's just that if you can choose to biopsy not the nail, that's what you're going to go for. For example, lupus, if you have a lesion on the arm, of course, you'd rather biopsy that than any nail dystrophy. So I just want to concentrate in the interest of time so we can get on to other subjects on psoriasis and lichen planus, which are, that's sort of the top two things that are usually of interest in the nail in terms of when biopsies occur. And so psoriasis, I think many of you know this too. And again, this is supposed to be a clinical pathologic lecture. And so if you've not really spent a lot of time thinking about psoriasis, these are some of the common findings, which are onycholysis, which you can see a little bit here and a lot here. Oil spots, so we'll see the reasons for this histologically, but accumulation of serum and neutrophils gives you oil spots, and then usually you end up with onycholysis distal to that. There's maybe a little bit of whitening here that is leukonychia due to, as we'll see, distal matrical involvement. And nail pits, which we'll look at in a second as well. So we talked about the proximal matrix producing the surface of a nail plate. And so now it makes sense that anything that causes, let's say, some parakeratosis to form from the proximal matrix will end up on the surface of the plate. And as that plate exits the protection of this proximal nail fold, that parakeratotic focus is going to fall out, and you'll either get a pit, or if it's really big, you'll get crumbling. So this is how we get that surface change. And this is a newer diagram that I kind of edited a little bit, but just showing what we just looked at here from that classical picture from Nardo Zayas. And then when you get parakeratosis stemming from the distal matrix, then you'll get leukonychia. So you'll get retained nuclei in the plate and a white nail. And then everything else in psoriasis, oil spots, hyperkeratosis, onycholysis, all nail bed disease. All right, so let's take a look at some of this in actual sections. So nail pits, we talked about proximal and dorsal matrical involvement, sometimes the ventral nail fold, surface parakeratosis, leukonychia, distal matrical involvement, parakeratosis of the midplate. Splinter hemorrhages is the nail's Auspitz sign, where you get those vessels that get to be a little bit more superficial under a thinned epithelium. And again, that's a nail bed sign, and then you'll get a little hemorrhage longitudinally. Onycholysis and oil spots is again from the bed. Serum and neutrophil accumulation or pustules can also give you onycholysis. So acrodermatitis of Halipote pattern of psoriasis may give you onycholysis. Thickening of the nail and the subungual material is from the bed and the hyponychium, and that's hyperkeratosis, serum and neutrophil accumulation. So this is a lovely example of a lot of things that we just talked about. So we have onycholysis. You might be able to make out some nail pits here in the surface. You've got some oil spots. Maybe there's a couple of splinter hemorrhages here. And a nail clipping of this patient was fabulous because it showed all of the above. So this was one of the best examples I've ever had of nail pitting, which you can see here and which we'll take a closer look at. So nail pits, and we've got our subungual hyperkeratosis and neutrophils. So this is what gives rise to those other nail bed findings. And here are the pits, and you can see these little lenticular shaped bits of parakeratosis that then fall out, and then you get a little surface defect there. The key thing here is that you can see the same types of things in onychomycosis, identical findings of parakeratosis and neutrophils in the subungual space. So you've always got to do a PAS stain on these types of cases. So nail bed psoriasis, we already talked about, oil spots, splinter hemorrhages, and these are a couple of examples. One of my patients with some distal hyperkeratosis as well, and here's some splinter hemorrhages and onycholysis. Here you can see a nail bed sample with psoriasiform hyperplasia, and then some of that subungual material kind of drifted off elsewhere on the slide. So we'll take a look at these areas individually. You're not going to see hypogranulosis. That's kind of one of the hallmarks of psoriasis everywhere except acral skin, okay? In the nail unit, we talked about the fact that hypergranulosis is an abnormal but not specific finding, so it's not uncommon to see it in psoriasis. Here are some of those prominent vessels. You can see some thinned epithelium here. You can see some parakeratosis sprinkled with a little bit of neutrophils. You can see some, quote, thin ridges, not reedy, here as well, another clue. More of the close-up of the neutrophils and the vessels that would give us our Auspitz sign and the hypergranulosis. And here's that subungual material, again, serum and neutrophil accumulation. In Lichen planus, lots of different findings clinically. You have a lot of thinning and ridging and splitting. And then as it advances and as you lose the normal architecture, because the matrix is basically completely effaced by the inflammatory response, you'll see pterygium. And this is an irreversible scarring of the nail. So it's something we want to avoid. So clinically, we tend to treat lichen planus of the nail unit somewhat aggressively with pulse steroids and things like that. This is another case where it wasn't completely obvious what the condition was. Is it psoriasis? Is it lichen planus? There's a lot of broken nail and a lot of exposed nail bed. So this was the biopsy of that patient, and you can see histologically the onychorexis, so the splitting up and shattering of the nail and the thinning and atrophy of the nail because basically the matrix is being attacked and it's not producing a consistently normal nail. And you can also see some marked hyperkeratosis and then the kind of typical band-like infiltrate that we see in lichen planus elsewhere, and of course hypergranulosis. A case like this is also tough. And I saw this patient in clinic with Dr. Yu. We were talking about where the biopsy should come from. And if you biopsy here, it's pretty thick and it might be hard to sink a punch through there. If you biopsy this exposed nail bed in any condition, if you biopsy exposed nail bed, you may not find any diagnostic features of that entity. So in this case, I suggested, how about our gold standard longitudinal excision. And that turned out to be perfect. So this was this actual biopsy. And you can see that a lot of the hyperkeratosis we were seeing was actually above the nail plate. This nail plate is actually quite thin. It possibly some of this hyperkeratosis was coming from the proximal nail fold area. You can see the band-like infiltrate. You can see if we tried to sink a punch here, that would have been tough. This would have been easier, but look at the problem here. There's no inflammation there. So it tends to be a very patchy infiltrate in lichen planus, which is why a longitudinal biopsy in the thin plate there is really a great technique, the hyperkeratosis there. And again, typical findings of lichen planus anywhere else, hypergranulosis, band-like infiltrate, more of that band-like infiltrate intermittently here with some necrotic keratinocytes, but in some areas, very little inflammation. And in some areas, as we saw distally, almost no inflammation. What about pterygium? So again, when you've got this lichenoid infiltrate going after the matrix, eventually the matrix stops making a nail plate. If you don't have a nail plate growing, you lose the architecture of the proximal nail fold versus the nail bed. You get this sort of syncytium, and that's the pterygium. And so when that happens again, that's it. You're never going to grow a nail back there again. So this was a longitudinal excision of that patient. Here you can see this is where is our normal architecture, right? With our lovely keratogenous zone and even our nail plate. There's almost no nail plate to speak of. Patchy lichenoid infiltrate is here, but this is where the matrix would have been. And here you can see this has now become this sort of syncytium of the proximal nail fold and the matrix and the nail bed. And eventually that whole nail plate and nail unit will just be lost. And there often is some fibrosis here as well, a little bit of scarring that happens there. All right, so diving into Melanonychia, and I'd like to get through Melanonychia if we have time. I put in some a couple epithelial entities at the end, but this is really the most common reason to do a nail biopsy that we have because of the stakes involved. We're worried about melanoma. So I want to make sure we spend time on this. If you guys want to go a little longer, I'm happy to do that if whatever you guys like, or if we want to have some questions, however Dr. Davis wants to do things, but let's make sure to get through this. So if you were trying to figure out which one of these lesions was the melanoma, you might find it difficult, right? This is really broad and really dark. This is really broad and really streaky. This is really broad and complete melanonychia with some Hutchinson sign here, some distal pigmentation here. And some of these are quite narrow, maybe not as scary. This is the only one that's melanoma, and these two are actually, this is a nail lentigo in a child and a nail nevus in a child, and this is another nail nevus in a child. So sometimes these are super scary clinically, and they can even be very challenging histologically. So we'll go through all these clinical aspects as well. Causes of nail pigmentation. So melanocytic activation is a very common reason for pigmentation. It's also called hypermelanosis. Basically, it's increased melanin in the nail plate and sometimes the nail epithelium, but without a melanocytic neoplasm. So just pumping out melanin. And it can be due to trauma, medication. It's the cause of multiple pigmented bands in patients of darker skin tones, endocrinopathy, pregnancy, Poids-Jaegers and Laugier-Hunziker syndromes. But basically anything that disrupts the nail unit can cause it. So inflammatory diseases, some neoplastic diseases, even onychomycosis can do it. Melanocytic proliferations, we all know from other places, lentigo, nevus, melanoma. And then we saw some pigmented onychomycosis as a cause for nail pigmentation, but you can also have pigmented squamous cell carcinoma. You can have Onychocytic matricoma, which is a newer entity, nail hemorrhage, et cetera, it can cause pigmentation. Nail apparatus melanoma is most common in older patients and most common on the thumb and the great toe. We know it has a higher mortality than conventional melanoma in a number of series, especially this very large series that I have referenced here. And the problem is that it is often diagnosed at a greater thickness initially. So in some series 4.8, and I believe in this series 4.8 millimeters. So that's a thick melanoma. It usually arises in the matrix. So 75% of melanomas demonstrate melanonychia. Sometimes it'll rise in the nail bed, and that is amelanotic because nail bed melanocytes are very few and far between, but they also don't constitutively produce melanin. So those are the real tricky ones. You may have, usually you'll have an irregular pigment band greater than 3 millimeters, or now we're using sort of 40%, because it depends on the nail, right? 3 millimeters on the pinky is not as bad as 3 millimeters on the thumb, perhaps. Hutchinson sign, periangular pigmentation, very worrisome as a sign of very poor circumscription. And we have to keep in mind it's exceedingly rare in children. And even some of the cases that have been published in the literature as melanoma, in retrospect, the authors realized, I think that probably those were just really atypical nevi, probably not melanoma with what we've learned since then. And there's never been a case of metastasis melanoma in a child, with the exception of melanoma that was thicker that arose in a congenital nevus that happened to involve the nail. So again, it's rare and it's also very low risk. So we want to be careful not to overdiagnose that and do, and over surgerize these kids. So the ABCDEF rule for melanoma is a nice little framework referenced here. And then this other, again, recent update of this by Dr. Sharon Lipner and Dr. Cohen Ormanda that talks about using the 40% of the width of the nail and what other features are important here as a nice guideline. So the age I mentioned, greater age is very questionable if darker skinned patients have a higher incidence of nail unit melanoma. That's been said, but it may just be that they have a higher proportion of nail unit melanoma compared to other cutaneous melanomas in patients with darker skin tones who tend to have a lower risk there. The band is usually black to brown, again, greater than 3 millimeters or perhaps 40%. There may be a blurred border. Change in the nail, enlarging or darkening, a lack of change or response to treatment for a nail dystrophy. And I'll show you a scary case in a minute. The digit, again, the thumb and the great toe are the most common, followed by index finger. A single band is more worrisome than multiple bands, of course, on multiple digits. And then the dominant hand seems to be involved more than the non-dominant. Extension of pigment onto the surrounding tissue, that's the Hutchinson sign. And then a family or personal history of melanoma may enter into. So here's some illustrations of melanoma from Eckhart Haneke, another god of nail disease. And here you can see many different patterns. So here, a broad streaky band, also with some Hutchinson sign here. Here, a broad band that even may extend this far with, bands within it that are irregular in spacing and thickness. This is a worrisome sign, the triangle sign, where you have a band that's wider proximally than distally, because that may signal more rapid growth. And here you can see that it probably started in the matrix, got onto the nail bed, and then now is extending onto the hyponychium. The thing about the triangle sign is this is not uncommon in evolving nevi in children. So again, we have to use maybe a little higher, we do have to use a higher threshold for diagnosis of melanoma and our concern factor in kids. And when you get to this point where you've got maybe some nail destruction, you might be dealing with an invasive melanoma. And here you can see extensive Hutchinson. Here's some amelanotic melanoma. These are the real foolers because they often come in as pyogenic granuloma or chronic paronychia or some other neoplasm such as a squamous cell carcinoma. And again, they usually arise from the nail bed. Here's one of the scariest things I ever saw at a meeting. 3 cases of amelanotic melanoma that looked a lot like Lichen planus. The key thing here was that it was 1 digit. So if you ever have 1 digit that has a nail dystrophy, you have to always have in the back of your mind, could this be a neoplasm? More often it'll be squamous cell carcinoma, but have to keep melanoma in your mind as well. All right, so what are the criteria for the common causes of melanonychia? Well, melanocytic activation, as I said, that's just melanin without an increase. Oh, Siri is talking to me. I don't want to talk to you, Siri. Sorry about that. Melanocytic activation, again, increased melanin and no increase in the normal density of melanocytes in the matrix. So usually these present with a narrow band that's tan or gray when solitary. That can vary. Again, this is the cause of multiple pigmented bands. You'll have increased melanin, but without increased melanocytes. So what is the normal density of melanocytes? In a couple of different papers, 4 to 9 across the millimeter of the matrix is about in the range of normal. And they may be they're usually very inconspicuous in normal sections. And it may be even less than that and you do need usually immunostaining to be able to make that assessment. A lentigo, again, usually a narrow band that's tan to brown to black. Here you'll have increased single melanocytes. And in this nice paper from Dr. Bijalamin and Klaus Busam and colleagues, they looked at the differences between lentigo and melanoma in situ and showed some differences in the density from about 10 to 31 across the millimeter, a mean of about 15 for lentigo. And we'll see that it's greater for melanoma in situ. But we'll talk about a pitfall in just using density to make that call in a second as well. So in a nevus, you can't really just use single melanocyte density, obviously, because you've got some nests now, but the clinical is very similar to a lentigo. And again, you've got the nests of single melanocytes, and usually in a somewhat sloppy array. It's not as orderly as in other cutaneous sites, except it's more like acral nevi, where they get also very disorderly at times. So melanoma in situ, we looked at some examples of this already. In terms of histologically, the mean density of melanocytes across a millimeter, again, in this one paper, was from 39 to 136. That's pretty high. And usually that involves a lot of stacking of melanocytes. What I want to call attention to you is this, and this has been a pitfall I've seen and stumbled into myself, that the high end of a lentigo isn't really that much different than the low end of melanoma in situ. And imagine if you've got sort of a paucicellular area of melanoma in situ, and that's what gets sampled, you can kind of get into trouble there. So again, you've got to look at other features. So here's where we're going to pay more attention to the distribution, if there's confluence, really looking a lot at cytologic atypia, suprabasilar scatter, irregular dendrites of varying thickness perhaps, and periungual extension. So extension onto the nail bed, extension onto the undersurface of the proximal nail fold at eponychium. So here's melanocytic activation. And this is a lovely punch. And there was actually, the nail plate was also submitted in this case, and it showed some melanin in it as well. And this is that kind of light tan band that you can see here, relatively narrow. And melanocytic activation is the most common cause of melanonychia in adults. So in children, it's often nevi or lentiginous. So you're going to see this clinically and histologically. And the usual response to these cases is in routine sections is I don't see anything at all. I can't really see what's wrong, but you can't give a report like that back to a clinician who's just done this biopsy or to the patient who just had it done. So you've got to dig a little deeper. So again, level sections are something I try to do. I try to be a little cautious to not exhaust the tissue as if I need to do immunostains or molecular studies. But here you can see that a Fontana stain is super helpful here. It illustrates some of the melanocytic dendrites here, which are very, very thin, and some background melanin. And then a melanocytic marker. I like the nuclear markers, SOX and MITF for this. I now use a red chromogen, which helps with really darkly pigmented lesions. SOX10 can fail. I've seen a number of failures of this. And so you've got to sometimes, if be suspicious if it's completely negative, back it up. And the most reliable stain in this setting is Melan-A. But as I'll show you, it can sometimes over-exaggerate the density of melanocytes and make things look a little bit scary. That's melanocytic activation. Lentigo, this was a narrow band in a child that had a blurry border, and the parents were very concerned. So she underwent a little biopsy, and here it is. And here you can easily see the melanocytes here. Again, they were very inconspicuous in what we just looked at, but in a lentigo, you can tend to make them out a little better. You may see some melanocytic dendrites, and to assess the extent of this, you can stain it as needed. This is another lentigo, but this was in an adult, and there was a high background pigmentation, really hard to figure out what the density of melanocytes is here. But this was a very narrow band. It was described as a 1 millimeter band, so maybe a little less concerning. But one of the things that concerned me was that there's some kind of chunky dendrites around in the vicinity. So that deserved a little more. So here you can see a Melan-A staining of this particular lesion with a red chromogen, and it kind of had a little bit of a discontinuous appearance, but it was very circumscribed here. And again, it highlights the melanocytic dendrites because this is a cytoplasmic marker. And you can count the density here, and there's a little bit of stacking, but it wasn't bad. And you are going to see a little bit of stacking of nuclei in the nail matrix because some of these may be residing along the base of an adjacent ridge. So you do get, I usually like to say if the melanocytes are generally in the lower third of the epithelium, I'm feeling pretty comfortable. All right, and here's a SOX10, so a little more relaxing. Here you can see individual nuclei, really easy to do a count. You're not getting all the background staining, and maybe it's a little bit less density than the Melan illustrated, but still a very low density in the range of a lentigo and definitely not in the range of melanoma in situ. All right. Nevus. So in nevus, this is a lovely example with very good margination of the band. And it's a nice illustration also of the pseudo-Hutchinson sign. So a dark band here that's well marginated, you may get reflection of pigment through this transparent cuticle and even through this relatively thin proximal nail fold. And sometimes you'll see that kind of effect even in the lateral nail fold. You'll see a little bit of that transmission of pigment. All right, and this is the excision from that lesion, which is lovely longitudinal excision. You can see all the different compartments here. You can definitely assess if there's an extension onto the nail bed, which there wasn't, or onto the eponychium, which there wasn't. So wonderful technique. And here you can see a little bit of confluence of nests, but in the longitudinal plane, sometimes that happens and they're less discrete. But again, they're all in the lower epithelium. There's one little nest that ended up in the matrix here. And this also reminds us of that relationship with the nail matrix and where does the pigment go or where does the parakeratosis go depending on what compartment of the nail unit is involved. So here the distal matrix is involved, and so the pigment is ending up in the lower portions of the nail plate. And you can even use a dermatoscope and look at the end of the nail and figure out, you know, where you think this lesion is based on where the pigment is in the nail plate. So that's kind of fun. The melanocytes here are very uniform. The nuclei are small. This is a keratinocyte. It's not a melanocyte floating up. So that sometimes scares people when I show this picture. And then there's nothing going on here in the eponychial epithelium. It's very well circumscribed. There's the pigmentation. There's a closer look at this lesion. This is a nail unit nevus in a child, and sometimes the nests are kind of inconspicuous. The melanocytic nuclei in the nail matrix are similar in size to the keratinocyte nuclei, so they kind of blend in a little bit. So again, a melanocytic marker is very helpful in kind of teasing these out, and you can see it's a mostly nested proliferation, which is very reassuring. But again, it's kind of sloppy, right? We've got a little bit of single cells. We got a little bit of an irregular distribution of nests, single cells. This is acceptable in a nail nevus, but again, it's all kind of in the lower third or so of the nail, and there's no melanocytes anywhere in the epithelium here. All right, Melanonychian children, though, we already talked about them not playing by the rules, and that nevus and lentigo are the most common, and melanoma in situ is rare. The nevi may be broad and involve periangular skin, and they may have blurred borders. We've already seen examples of that. They may also be unstable, so they may develop quickly, they may broaden quickly, they may fade quickly. There may be nail plate abnormalities, so you may start seeing nail dystrophy, which would otherwise maybe make you nervous, and that's illustrated in the image that I have here in the upper right. I hope you guys can see that. Mine is blocked a little bit by the panel here of people on the call, but hopefully you can see all of these things. And then the histology can be disturbing, and that's one of the major areas that generate consultations for me as nail unit lesions in kids, because they make people very worried, and especially the parents. So this is an example of a 1 millimeter band in a child where there was extrusion of melanocytic nests, and that we didn't have much of the base of the matrix here, but we could already tell this isn't normal. They shouldn't be all the way up here in the keratogenous zone. And there were also melanocytes in the nail plate. So certainly supravasilar scatter was happening here. This is another unfortunate case where an initial biopsy was read as very atypical because of the sort of spitzoid morphology. And rather than doing a conservative excision, this 8-year-old boy actually had an amputation of the great toe. So we've got to kind of keep our cool with these and not overreact. So if you get a scary kind of report back as a clinician, meditate and then say, okay, this is a nail unit in a kid. Can we, walk this back a little bit? Can we, get a little more relaxed about this, but certainly not overreact surgically. All right. This is a great article in the JAD in 2018, comparing nail unit nevi clinically and histologically in adults and kids. And here's the kids, and look at some of these, right? Really broad Hutchinson sign, which turns out is a little bit of brushy pigmentation, which is kind of very common in nevi in kids. Really worrisome, some of these lesions. And then in nail nevi in adults, which are generally more relaxing and narrow, and as you would expect. Histologically, they showed some of the same things I've seen over time, which is the suprabasilar scatter, some cytologic atypia, crowding, things like this. So again, we got to kind of keep our cool. I think we're going to go past 5 because I think we started a little late. Is that okay if I wrap it up with melanoma?
Oh yeah, that's great, Beth.
Okay,
Please.
you guys just put the hook on, just tell
No,
me.
no.
I'll plan to finish melanoma, and if you want to go a tiny bit more, I can do that. I'll let you guys be my guide, okay?
Sure.
So melanoma in situ, this is a nice example, a broad streaky streak that also had some little funny pigment globules in it. And there was a micro Hutchinson sign you can see here. And a dermatoscope is a great way to see a micro Hutchinson sign, which is a very worrisome finding in adults especially. This is that case. This was a punch through the proximal nail fold. And so I think you can easily see how atypical this is. Very confluent. There's hyperchromatic nuclei, so there's cytologic atypia. There's definitely suprabasilar scatter here. You can see melanocytes are floating up through the keratogenous zone and also ending up in the nail plate. And again, we talked about in nail clippings, how once in a while you will see melanocytes there, and that is a worrisome finding. And then this is, as you guys know, because now you're experts, now you know this is the keratogenous zone, that band of pink. This is the eponychium, right? Undersurface of the proximal nail fold with its granular layer. This is the Hutchinson sign. So this was the very subtle extension of that lesion onto the eponychium. And as you can see, it looks kind of boring, so it's kind of, the melanocytes are kind of comparatively small. There may be just a lot of single melanocytes. Sometimes there aren't melanocytes at all in the Hutchinson sign. It may just be pigment. So that's another caveat. If you got a lesion, it's got a Hutchinson sign, and you say, hey, I'm going to biopsy the Hutchinson sign because I don't want to do a whole nail unit procedure, you have to keep in mind that the Hutchinson sign histologically can be somewhat bland. So there you have it. So here we got a very atypical looking lesion, as we just said. Early MIS, you're starting to count the nuclei, you're doing your stains, you're looking for cytologic atypia. Here's a atypical cell with a hyperchromatic nucleus, bad circumscription. Maybe you'll look for some irregularity of dendrites here and there. This is my husband will be quick to say he only did the biopsy on this case, not the re-excision. My husband is a dermatologist too. And you can see this is a very darkly pigmented band with a micro Hutchinson sign, and actually had some little white areas. And it turned out this was one of the few cases I've seen with regression that was pretty well developed. So this was the second procedure on this case, the re-excision of this lesion, and a longitudinal complete nail unit excision, actually. And you can see our typical architecture. And what's nice about these, as we've talked about, is how they pull all the pieces of the puzzle together. So you can see the full extent of this, which involved the proximal nail fold. You can see the patchy inflammation here that gave rise to some of the regressive looking areas. And then of course, higher up, you can see this marked atypia, suprabasilar scatter, a lot of irregular pigmentation in the nail plate, including some very irregular globules. I kind of use that as a sign of something to be concerned about. Invasive melanoma turns out not very hard usually to make that diagnosis, because things have really become quite easy to diagnose. At that point, you've got usually a very irregular intraepidermal component, a lot of cytologic atypia, you've got an irregular dermal component, you can maybe spot some mitotic figures here. And let me just point out, and this was the lesion, this was actually somewhat amelanotic looking, even though this arose from the matrix. This gives you an idea. This was an excisional biopsy, and it wasn't intended to take out the whole thing. But one thing to point out is that this is that proximal matrix I talked about, which got transected. So we do want to make sure in a complete re-excision to get that proximal matrix to prevent regrowth. This was the nail plate overlying that lesion, and this was a really instructive case because we got this first, and this was, kind of something you could go down the tubes on. And I have seen medical legal cases where that was the issue, that this wasn't recognized. So this nail plate, as we talked about, has a lot of attached epithelium, as nail avulsion specimens do. And you can orient yourself to where you are. You've got the proximal area here with the keratogenous zone and part of the proximal nail fold. And the key thing here was that there was just tons of suprabasilar scatter in this epithelium and also in the nail plate. So you could say this is melanoma, at least in situ, and kind of go from there. But this is often overlooked. People are often just looking for pigment in the nail plate and ignoring the epithelium. So gotta keep that in mind. Here's again some more atypical findings here. All right, what about staging of nail unit melanoma? We'll close with that. And just a brief mention of what is the treatment, again, to kind of calm people down from over-treatment of these lesions. So basically, it's the same as the AJCC staging. There's no independent staging criteria. The measurement of thickness can be difficult if the nail has been avulsed or if there's ulceration, of course. And we're often dealing with partial biopsies in the beginning. So that may limit your assessment and not allow you to completely figure out treatment planning based on those. This was a thick amelanotic melanoma that was thought to actually be a squamous cell carcinoma clinically. One of my former colleagues at UCSF did a lovely punch of this biopsy initially, and it required, of course, staining to make the diagnosis. And then in the re-excision, which was actually an amputation specimen, but we removed the soft tissues from the bone, also to preserve the ability to maybe do some molecular analysis if needed for treatment purposes. But here you can see this very thick lesion that's ulcerated. And what you want to do in this case is measure the thickness to the greatest extent. And then, of course, you're going to comment on ulceration, and then you're going to look for the same things you do anywhere else, the mitotic rate, whether or not there's other adverse prognostic features, such as in this case, there was perineural invasion, and there was even lymphovascular invasion here. Conservative surgery. Okay, so back in the day, just like for melanoma everywhere else, very extensive surgeries were done. And we now know they weren't serving the patient. They didn't change prognosis or outcomes. We used to do these giant amputations, four-quarter amputations. We went to, for the nail unit, we went to ray amputations of the whole digit and the whole metacarpal, phalangeal, everything. Then we went to just digital amputations, and then we went to distal digital amputations. But now we know that we can actually do even more conservative surgery. So you can do just a complete nail unit excision and then grafting, leaving that function intact. So this is also called functional surgery, which you can use for melanoma in situ and some thin melanomas. And to my way of thinking, even some thicker melanomas, because will a more radical procedure really change the prognosis in a very thick lesion? That's kind of controversial. There's a study out of Bologna a few years ago that raised that question as well. They followed out a lot of these advanced melanoma patients, and having done a more radical surgery didn't change the outcome. So I think this will evolve even further. So what you do here is complete removal of the nail unit, and usually graft is put on. Like we've already talked about, you want to make sure to remove all that matrical epithelium and maybe even a little bit of superficial bone, just to make sure that you've really cleared out all of that nail epithelium and dermis, that very narrow area that we've got there. And then, of course, you want to follow these patients long-term for recurrences. And recurrences have been reported in some of these articles. They tend to be very limited and melanoma in situ. So that's also good. So this is the technique. Basically, complete excision of the nail unit down to the bone with a margin, usually 5 to 6 millimeters, and then a graft. So it looks pretty good. And this is the type of specimen. So again, you want to be making sure that you don't clip that matrix, and the distance from the proximal matrix to the bone on average is about 0.8 millimeters, so not very big indeed. And I think so again, we don't want to have that happen. I think that's my last slide of the melanocytic. I think I've hit my 60-minute allotment. So let me know what you'd like to do. Tom, we can stop. We can do questions. Whatever you like.
Beth, why don't you go ahead and cover a few of your favorites?
Okay,
Yeah.
there's only a couple of, in
Good.
the interest of time, I only put a couple more things in just in case. Sometimes I run loquacious, sometimes not. So one never knows.
Sure,
All right,
I'd love to hear about them.
Okay, so let's just do a couple. So I'm just going to show you actually just two. So there's lots of different, obviously, neoplasms that happen in this location, and some of them are very similar. For example, squamous cell carcinoma to what we see elsewhere. But a couple of couple of the top ones in the benign category that we see biopsied are onychopapilloma and onychomatricoma. So those are the only two I'm going to show you because there's a lot of fun nail things. But onychopapilloma is kind of an innocuous lesion, and it usually presents with erythronychia. So basically a pink or red band, and there's often splinter hemorrhages, as you can see here, and it usually arises from the distal lunula, so the distal matrix along the nail bed, and there's often, and what's not pictured here, a distal spicule, and that's often the thing that bothers the patients most because it gets caught on things. So all of these features can be seen. You can also see melanonychia, again, from melanocytic activation. So you can see a pigmented band sometimes causes confusion. Leukonychia, white band, and again, distal hyperkeratosis or spicule, and sometimes distal splitting of the nail. So the histologic features, which I'll show you, I think it's easier to show you than to read this list off. So let's just do that. Really, let's just preface it by saying really depends on a complete excision of that area, because partial biopsies, as I'll show you, often don't have the diagnostic findings, and it's disappointing to give that type of report back to the clinician. So again, you often need an intact lesion to make a definitive diagnosis, and let's go through all of these findings. So this was a lovely excision. This is a patient I was asked to see by the dermatologic surgeon. He said, how should I sample this? I said, how about longitudinal excision from the distal matrix? So again, an excision not likely to produce a permanent nail dystrophy. Here you can see the subungual hemorrhage. So this was our splinter hemorrhage that we're seeing. You can see a papillated distal epithelium, and this often mimics a verruca, but contrast the appearance of onychopapilloma with most verruca vulgaris of the nail unit, which usually starts around the edges of the nail and then secondarily involves the nail bed. So this is just smack in the middle. And let's see, as we get a little bit closer, you'll see sort of this very eosinophilic nail bed. And sometimes there's multinucleate cells in this area. And sometimes these make people nervous. I've had consultations where that was the sticking point, which is what are these, quote, atypical cells? Well, they're just multinucleate cells, and they are part of the name that this was originally given, which was a longitudinal subungual multinucleate keratosis, or in some order of those words. Here you can see that papillated distal epidermis, and you can see the subungual hemorrhage. This is another example of these really multinucleate keratinocytes. So if you see these, it's almost the only thing to think of in this setting is the onychopapilloma. This is an example of the so-called matrical metaplasia that you're supposed to see on the nail bed proximally in this entity. And again, very dependent on if you have intact epithelium. So it starts to sort of resemble the keratogenous zone where you have eosinophilic cells and retention of nuclei. So quasi-matrical metaplasia there. And to me, this is one of the many unicorns I'm always looking for in dermatopathology. Like, how am I supposed to be seeing this thing? This was one of the very rare cases where I actually saw it. So here, a nail avulsion was done, but luckily, a lot of the epithelium had been taken away from part of that specimen, and part of it was still there. And although I didn't have any of that distal papillation or hemorrhage or any of that kind of thing to use to make the diagnosis, this was a really nice example of matrical metaplasia, right? So I could say, hey, I think this is an onychopapilloma. And of course, I had really good clinical pathologic correlation. This is another one from an excellent dermatologic surgeon we happened to be residents together in dermatology, and classic onychopapilloma, and he sent me the photograph. So I knew like this had to be it. but unfortunately, a lot of epithelium had gone away with part of the nail plate, and what was left did not have diagnostic features. So I basically just had to, help with a clinical diagnosis and wasn't able to make a histologic one. So verruca vulgaris enters into the differential. You really want to look for very good viropathic changes, not just hypergranulosis. So perinuclear vacuoles, coarse keratohyalin granules, and again, clinical. This is how most warts start in the nail unit at the periphery, and then secondarily involve the actual nail unit, if at all. All right, last, onychomatricoma is such a beautiful tumor of the nail unit. It's one of the unique tumors of this area, and this was first reported in 1991 by Dr. Robert Baron, who, along with Dick Scher and Ralph Daniel, I would consider the real gods of nail disease, and Dr. Kent, his associate, and wrote about this lovely filamentous tumor. And this was the first one I ever saw, which was very typical of others, which usually consists of a nodule under the proximal nail fold, and then a thick and dystrophic nail plate that's often somewhat yellowish. So it gives you thickened yellow or xanthopachyonychia, thickened yellow nail plate, often with a transverse overcurvature and splinter hemorrhages. So those are kind of the key findings. And here you can see a little melanocytic activation is happening too, probably. And these can involve the whole nail unit or any subset of the nail unit. And this was the intraoperative photograph of this tumor. So she had reflected the nail fold and kind of popped this out. And this part used to be under the nail fold. And this is that thick nail plate. And you can see there's a little hollow area that is, again, that separation that forms between the nail plate and the matrix that we saw histologically, even in normal nail. And this is the specimen. So here's that more nodular portion. And then here is that thick nail plate. And this is another example showing this kind of worm-eaten proximal nail plate that you see in onychomatricoma. And we'll see the reason for that in just a sec. So the clinical features often in lighter skin patients, often on the fingers. I'm not sure I've ever seen one myself anywhere else but fingers. And I don't think there's been one reported on a toe, to my knowledge, at least to date. Women more than men, and we've talked about all of these other clinical findings. And once they're removed, they don't tend to recur. So the key histologic features are multiple fibroepithelial projections, thick V-shaped keratogenous zone that looks a lot like normal matrix, matrical hyperplasia, kind of a reduplication of it, and also extension of it over the more fibrocellular part, and a glove and finger appearance of the nail plate and the matrix. We'll see all this in a second. And then an altered nail plate, which is thin proximally and then very thick distally with multiple cavities within it, which gives you that kind of wormwood kind of pattern. And then a fibrocellular stroma of varying degree. And like many other acral lesions with spindle cells, it's CD34 positive, and it does cause confusion with especially superficial acral fibromyxoma and another entity that can happen in the nail unit. So you have to, if you want to exclude that, you have to do a kind of a panel of stains. Sometimes you will even see some atypical looking pleomorphic cells in the stroma. And so that's given rise to the term pleomorphic onychomatricoma, but they don't behave any differently than any other onychomatricoma. So remember our normal nail and remember our normal matrix. And we're going to basically see this reduplicated now. So this is the tumor I just showed you. And here you can see this proximal nodular fibrocellular component. And you can see this matrix, which has grown all over the surface of this nodular fibrocellular component. And each of these portions of epithelium, these V-shaped portions, originally kind of were stuffed back in here, but they kind of came loose during the procedure. So imagine that each of these kind of interdigitated here, and they were all part of the same proliferation. And so you get these V-shaped areas here and this kind of glove and finger arrangement of the epithelium to the nail plate. And then the nail plate's very thick. The epithelium is more digitate distally, and get these giant loculations of serum overlying these more papillated portions here. And this is also often where the hemorrhage ends up, in these loculated areas. So all of those things are what we saw clinically. And at a little bit closer view, again, these V-shaped keratogenous zones, where now you guys are experts on that, right? The matrical epithelium, which is kind of reduplicated and kind of a convoluted pattern here, and this fibrocellular stroma of varying degree. It can also be myxoid, again, causing confusion with other nail unit entities. And here's that really thick nail plate with lots of loculated serum. Some authors have mentioned that you can even find the epithelium very distal within the nail plate, and you can find it in nail clippings. I haven't encountered that myself, but that's been reported. But you can definitely make a diagnosis of Onychomatricoma from a nail clipping. So this was another classic presentation. I saw this patient in clinic with our nail expert, Dr. Vera Price. Classic nodule, classic yellow thickened nail with hemorrhage. And this patient did not want anything surgical done. She said, what's the easiest way to make the diagnosis? So nail clipping. So that's what we did. And it's nice to orient these transversely so you can really see these big loculations of serum and hemorrhage. And again, some authors have said you can even find some epithelium tucked up in here. A really nice technique. So that's it. That's all I got for you today on nails. And I hope that was a good tour, and maybe we'll think about getting interested in nails. If so, please get involved in the Council for Nail Disorders and International Nail Society and the European Nail Society, with a lot of fun people that are really interested in nail disease. So thanks so much for letting me present this to you today. And I'll let Dr. Davis decide if you want to do questions now or let everyone go. Everything in your control.
I think we're fine. I mean, we're just getting accolades here in the chat. No questions. If you guys have any after thinking about it, please feel free to shoot them to the education@sagesdx.com. And Beth, I'll go ahead and forward them to you. Okay.
Okay, sure, of course. You'll be able to answer everything. You know that. I'm happy to help, but
well, I can't thank you enough for all the effort here and all the knowledge you gave us, and just a wonderful presentation.
Thank you. You guys have been very patient, and hopefully I'm going to see this chat. Let's see what happened in this chat. Oh, thanks, you guys. You're very, very, very nice, and I really enjoyed spending this time with you. Well, thanks so much, Beth. Have a wonderful day. Have a great evening. Talk to you later. Bye. Talk to you later. Bye.